Okay, good afternoon, ladies and gentlemen. For you that don't know me, my name is Jan du Plessis and I work in the Department of Pediatric Hematology Oncology. Okay, so slight change. We're going to talk about the bleeding child today, approach to a child that is bleeding. Okay, just to shake things up a little bit. Okay, I've given you your crib notes that you can study from, and we'll ask you lots of questions from that. As you can see, one of the handouts is a little booklet on hemophilia. Okay, as you know, that's the most common inherited bleeding disorder of childhood. So who gets that, boys or girls? Boys. Why? Okay, so it's inherited X-linked recessive. Okay, so whenever you answer a question in an exam, answer in full sentences. Okay, it just sounds much better than it's like it's an inherited disease or it's inherited X-linked recessive. Okay, rather just than throwing out the terminology right there. Okay, so try and answer in full sentences. Okay, because it gives a better impression. Okay, so that little booklet has got everything that you need to know about hemophilia. Okay, at the back of those little booklets there's actually contact numbers of all the hemophilia centers and the heads of departments, nurses at the clinics who can assist you as well with everything about hemophilia. So that's a very handy book to keep throughout your training, and then obviously through your internship, and then throughout basically where you work. There might be a new one coming out, but that's the one that we've got at the moment, and that's to manage all of that. Okay, so I like to start with a few questions before we are going to start with the formal lecture. Okay, so we've got patient A, who's Lehlonolo, and he presents with epistaxis to your clinic or your rooms. Okay, so what is your first thoughts? Why would somebody's nose be bleeding? Okay, let's start.
In general, not speaking of...
Just in general.
You are thinking of trauma?
Trauma, okay, so trauma would cause what problem? So how would you bleed from trauma? Trauma to the nose, so it's basically rupture of the blood vessel. Okay, so second colleague, next cause, if you think physiology. Say again.
Hyperviscosity of blood.
Hyperviscosity, will that make you bleed? There's a lot of more symptoms that hyperviscosity cause. Okay, so what symptoms does hyperviscosity cause? Yeah, dyspnea. Okay, so there's more sludging and slow flowing of the blood. Okay, and then obviously the smaller blood vessels you need to think of. Okay, so that's more where that's going to come to. Okay, so that's not going to be your first thought when somebody comes in with a bleeding nose. Okay, so next cause.
Liver failure.
Oh, you guys going very in deeply, eh? The poor child, all I said was that he had epistaxis. There was no other history given, but you're already making him liver failure. That's like that's the most common cause for nosebleeds, isn't it? Liver failure. Hey? Okay. Okay, so allergic rhinitis, something local. Okay, so think of common causes first. Okay, that's what you guys do in the exams. Okay, you come up with this ridiculous, most rare, uncommon causes as your first answer. Okay, and that's what you guys must watch for, the obvious things first. Okay, so if we just think in broad terms, we said it's a vascular problem. Allergic rhinitis obviously as well. There's congestion of the nose, so the blood vessels probably more brittle and fragile, so that's why you would bleed. Okay, what's the other main causes? You haven't asked me anything else about the patient. So what's the big groups and what's the questions that you need to ask? You wanted to know if there's trauma. Okay, so you want to know if he's in liver failure. He's definitely not in liver failure. Okay, so yes, you can pass.
Is the coroner perhaps on any medications?
Yes, he's on several medications. Why would you like to know about medications?
Because medications, they can cause thrombocytopenia, or they can affect the way that...
So what medications do you want to know about?
So you want to know about NSAIDs?
Okay, so something affecting the platelets. Okay, so we're getting there. We've got a vascular problem, we've got a platelet problem. Okay, and what's the third cause for bleeding? And I think this is what the young lady here was insinuating, clotting factors. Okay, so but clotting factor, liver failure is not the most common cause for clotting factor failures, or okay, so clotting factors. Okay, so you need to ask me a few questions to try and get to an answer with this young man.
How long did he bleed for? How long has the nursing been going on?
Well, it started last night, so hasn't stopped yet.
And has he had these nursing before?
Yes, multiple times.
And does he bleed anywhere else?
No. Where else would you like to know? Joints? No, definitely not joints. Skin? Yeah, there was one time that he was admitted for quite some time in the hospital, and he had a few petechiae. Gums, yes, where he bleeds when he's brushing his teeth. Pardon? Family history of what? Father and mother is perfectly well.
Is he systemically ill?
He is not currently systemically ill.
Are there any other symptoms? Is he tired? Fatigued?
He's a bit fatigued, yes.
Confused? How bad?
Not confused. He's nice and awake. He faints at times. Grandparents also perfectly normal.
Is the HIV positive?
Negative. He's HIV negative, yes. He's had multiple blood transfusions. He's had about 12 last year. So what problems could that give you? And why did you ask that question?
Sorry, I'm not answering. Okay, if he had inherited disorder, platelet problem, clotting problem.
Okay, so what else would you like to know about him to figure out if there's an inherited problem? Okay, he does not have hemophilia. So would you transfuse a hemophiliac 12 times a year? No. Why would you transfuse somebody? They drop their hemoglobin, so they lose quite a lot of red blood cells on a regular basis. Either they lose it or they don't make it.
After trauma, does he have
Or destroy it.
any superficial trauma? Does it also be maybe to the skin?
Yes. Does it help you? What would you like to know about them? HB, currently hemoglobin is 8, platelets of 40, and a white cell count of 3.
Did he have a peripheral scan?
Yes.
Did he have any fragments?
No fragments. Perfectly normal. Perfectly normal. No. No malignancies. He's not jaundiced. His haptoglobin was normal as far as I can recollect. We haven't done that recently.
Has there any local abnormalities in the nose?
We've had the ENTs look at him, but yeah, it's just nothing, no abnormalities.
I know we asked about family history of one friend. Is there anyone else in his family who's had a bleeding tendency?
Nobody has had a bleeding tendency, but he and his younger brother look exactly alike. The middle brother doesn't look like the two of them.
Doesn't look like the parents.
No, it doesn't look like them. The two brothers.
Oh, there's another brother.
Yes, there's three brothers. So there's the youngest, looks like him.
Is he growing now?
Well, he's growing he's following his central line. But everything is on the -3Z line.
Have you ever seen?
No,
Is he malnourished?
no.
What's the age of the patient and where does he reside?
He's 11 and he resides in Bloemfontein.
Why would he give his blood transfusion?
Because he had low hemoglobins. Well, he was bleeding, and that's what I need you to figure out.
And his stools?
Perfectly normal. He has vomited blood now after the epistaxis.
Is he HIV positive?
No, we already asked that.
Is it warfarin?
No.
Does he have a bone marrow?
Yes. He had an aspirate, and that was hypoplastic.
Concentration of factor VIII.
His clotting times were perfectly normal, so they were all normal. Okay, come on, you're on the right track. Yes, you need to think of aplastic anemia. He's had a chronic history. You don't get just 12 blood transfusions for any other reason, okay? So, and he's presented with low platelets, okay? So I've given you the answers everywhere, but nobody has asked about what he physically looks like. So he's actually got an inherited... No, you didn't ask. Yes, you didn't ask. So he is short for his age. He's got a smaller head circumference. His eyes are smaller, almond-shaped. He's got a puckered-shaped mouth. He's got hyper and hypopigmented skin lesions on his skin. Okay, he's got radial muscles, basically. Or let's think about it. His thumbs were abnormal. Okay, but basically with him and his brother, that was just thenar muscle atrophy, and he's got a pelvic kidney. So what disease am I describing? Fanconi. Okay, so this young man presented with epistaxis and it is bleeding. Okay, so first of all, obviously I needed to discuss it with the ENT surgeons to try and treat the local cause. How would I stop his bleeding? Who's got the microphone? Give to your colleague next door. You've had answers. So, how am I going to stop his bleeding? Okay, yes. His platelets are 40. Yes, you would. How much? Okay, so obviously he's bleeding because he doesn't have platelets. Yes, he could have had flu or whatever as well, but he doesn't have platelets. Okay, so he's not going to stop if you don't give him platelets. Okay, so every single time that he comes in, we need to give him a platelet transfusion. Okay, and because he's got an inherited bone marrow failure syndrome, okay, so it's basically aplastic anemia, he's not going to make red blood cells. So am I going to transfuse him or not with a hemoglobin of 7? Yes, his case you most definitely will, okay, because remember his bone marrow is not going to recover, he's not going to make blood at all, okay, so he will need blood as well, okay, despite the fact that people would say that only transfuse less than 6, or depends on what the condition is. You need to look at your patient individually. As well. Okay, so that was case number 1. We will talk about case number 2. Okay, but what we need to, those are the subjects that we're going to cover a little bit about the physiology that you guys need to know, the bleeding history, physical examination, how you're going to screen, and what your diagnostic approaches are. Okay. As we started, this boy had epistaxis. We thought, like we say, he was bleeding. So 3 things happened simultaneously. Okay, so if the blood vessel was broken up or interrupted, you basically get your first phase is the vascular construction. Okay, so that's how the body tries to stop it. Then you make your platelet plug, and then after that you basically make your fibrin thrombus in the end. And these things take place simultaneously. Even though we discuss them separately, it takes place simultaneously as well. And as you can see in this one, and that's the reason why, because this gentleman asked about von Willebrand's. Okay, so where's the von Willebrand's has to do when the collagen is exposed, the von Willebrand's helps the platelets to adhere to the basically injured area. Okay, so that's why you need von Willebrand's. If you don't have it, then your platelets can't adhere and you will continue bleeding. Okay, so then you can't form a platelet plug basically, and it goes through all these reactions up to the end where you form a platelet plug. And then all of you know this lovely clotting cascade and can draw it with your eyes closed when I wake you up in the middle of the night, can't you? Okay, so everybody, there's a lot of people that wanted to ask me about the clotting factors all of the time. Factor 8, what side does it work, intrinsic or extrinsic pathway? Quickly, without looking. Intrinsic. Okay. Factor 8 deficiency. Prolong which? PT, PTT? PTT. Okay. Here it is. Factor 8. Lovely. Okay. Factor 9, just above it. Okay. And let's say you have factor 8 deficiency, I give you factor 8, and you continue to bleed. Why would you continue to bleed if I give you the appropriate factor? Okay, one person. You've got the mic. You don't want to, but you've got it, so please take it. Who would like to answer? You can develop antibodies, so that's another reason. Okay, so if you've got antibodies, basically your body makes antibodies, because remember the factor that you give, it's a foreign protein that you inject into the body, so it doesn't know it. Okay, and after a while it develops antibodies against it and fights it off, so it's not working. So how are we going to stimulate the clotting cascade then? Okay, because with factor 8 deficiency, if you don't have it, then we give factor that will stimulate the clotting pathway. Okay, factor 9, the same thing. If you don't have it, that's what we give to get your clotting cascade to complete and to basically make the fibrin thrombus. But now if your body made antibodies against this, how are we going to basically... Okay, so yeah, the answer is right here. You can either go further down okay, to use a factor called, do you know what are we going to use? Okay, so there's activated prothrombin complex concentrate, okay, which the other name is, because you get far more inhibitors or antibodies against factor 8, so the name is either fiber or fever, depends on which way you like to pronounce it, but if you spell it out, you will figure it out. It is FEIBA, so factor 8 inhibitor bypassing activity. Okay, so you can give that, or what other factor can we give? If you look at this, you'd need to use the extrinsic pathway, exactly, factor 7, okay. So then we can use factor 7 and then stimulate, okay. The problem with factor 7, very expensive, okay, extremely expensive, okay. I've had a medical aid asking lots of questions about the amount of factor that I gave to the one boy, because 1 milligram costs 7,500, it might actually be more, rand, okay. You give 290 microgram per kilogram stat and needs to be followed up within 3 hours. So you can give quite a lot of factor. So the one time I gave 64 milligram in total. Over a few days and weeks, he had a massive bleed, had a big thigh bleed, okay. So that we needed to give. So, but yeah, it can be very expensive, okay. So one need to try and then immune tolerate him afterwards, okay. But that's the reason why you guys got to know this cascade, okay. Know where the common factors work, okay, and what to do if they don't work, okay. That you need to stimulate from another pathway. And if you find an abnormality, like the phone call that I got from Uppington the other day, and they said that the PTT was prolonged, but both the factor 8 and factor 9 is low. How can you have both low in a perfectly normal child? That doesn't make sense. That has to be a lab error, okay. So just ask your question. If you find something, you get a result that you can't explain, rather repeat the test, okay. Get it done properly and then think of, okay, but how unlucky this person must be now to be factor 8 and 9 deficient. That is physically impossible, okay, because your mother, yeah, well, you'll have to be, I don't know how you have to be, because the father can't give it to his sons, basically, and the mother, if she's a carrier of another factor, literally, so she has to be, yeah, no, you can't get it, okay. That will be absolutely abnormal, okay. This is just a list of the factors and the factor names, and as you can see, the interesting one, Prof. Kutsia always tells a story about Christmas factor. Why do you think factor 9 is called Christmas factor? Do you think it was discovered at Christmas? Prof. Stones actually thought that it was discovered that the deficiency on a person who lives on Christmas Island, but that's not true. Okay? That's the first person who was thoroughly investigated, surname, who had factor 9 deficiency. So Christmas, okay. So that's why factor 9 deficiency is also known as Christmas disease. Okay. So just as a reminder. Okay. What I wanted you, when I started with a case study, to do is to take a thorough history, because obviously this young man is not sick, okay. So you need to take the history to find out why he's bleeding, okay. So there's an obvious reason, okay. And if this young lady, it can't be hemophilia, okay, unless she is extremely unlucky, okay. In which case is she going to be extremely unlucky? Let me see if I can go quickly. No, it's with the hemophilia lecture, which I'll show you. Basically, where the father is a hemophiliac and the mother is a carrier. Okay, and then if you draw that one, then you'll find out that you can get there. Okay, so one's got to ask the questions. These are the questions that you want to know, but in the end is, so yes, we wanted to know about the family histories, their bleeding history, medical history, extremely important. Okay, we're not just going to ask about NSAIDs. You need to ask about, all of us grew up, my mother gave me Disperins and all sorts of over-the-counter medications when we were little, okay? So there's all sorts of, in Afrikaans it's boererate, and I don't know what you guys call it, but anyways, everybody has got a little muti that you give for this and a muti that you give for that. There might be NSAIDs in all of those things as well. So you need to ask about all the other drugs, not just the medical drugs that has been prescribed as well. So medication. Nobody asked me if this child is actually one of my chemotherapy patients, okay, because chemotherapy agents can cause a pancytopenia, and that might be the reason why the patient is bleeding as well. So you need to go into that and how they clinically present, which you did ask where the bleeding was as well. So the age and the sex, again, you need to consider an inherited disease if the child started at a very young age, okay, with the bleeding. I was contacted with a child from, a 2-month-old from Monapo that had a hematoma, and that had a prolonged PTT, and then in the end his factor 8 levels was 0.4. Okay, so that's how they got to the diagnosis of hemophilia in this baby. And one's got to remember that hemophilia and all of that has got an implication on the whole family, not just the child, okay, because the family has to adjust the activities so that the child doesn't bleed all of the time as well. Okay. You did ask about the type of the bleed, the location of the bleed, the degree of symptoms, and then obviously what provoked the symptoms. Because the other case scenario that I've got for you is the young man that his father phoned to that he woke up this morning and he cannot bend his elbow. Okay, so why would somebody not, from your sleep, unless you fell out of bed and not remembered that, woke up with a swollen, painful elbow? So what does that make you think of? Pardon? Hemathosis, okay. So he's got a bleeding history. There was a massive bruise that nobody knows where it comes from, okay. So that is most likely could be hemathosis. It was not hemathosis. It was actually a muscle bleed that he had, but it just was because of the extent of it that it was too painful to bend his arm. As well. So this is the question, this is basically that you need to answer. Is there a problem with the hemostasis, or is it actually an appropriate response? Okay, so because if he fell off his bicycle and bumped his nose, or he was hit with a fist in his nose, that is very appropriate, that he can bleed from that, okay. But this young man, minimal trauma, no idea why, and he was bleeding, okay. I've tableized the common ways that these patients could bleed with the histories that they present. Why did I do this? Obviously, it's to tickle your imagination and to think of it. If a patient presents like this, you've got to think of this type of disease as well. And then there's the little thing called multiple choice questions. Okay, so I'll give you a typical history and then you've got to answer the question from there. Okay, so as you can see there, we all know the typical history for hemophilia: male infant, painful swollen joint, could be after a fall, it doesn't have to be after a fall as well. Von Willebrand's disease, the adolescent girl with the increased menstrual bleeding, recurrent epistaxis and pallor. Okay, so you guys can go through this. One must just remember all these little rare ones like factor 13 deficiency that you can also get. So bleeding from the umbilical stump, intracranial bleed in a 10-day-old infant without any apparent cause for that. As well, the acute ITPs with a recent history of a what type of infection? Viral upper respiratory tract infection. Okay, and when does ITP become chronic? So when is a disease chronic? Next lady, you've got after 2 weeks. That's a little bit shorter. That's still acute. Yes, 3 months. Okay. When I looked at the formal definition thereof, 3 months is usually the cut-off for any other disease, if you've got that. But in ITP, it's after 6 months, okay, because it can recover. But if it continues after that, it's usually a 6-month history that you can present with as well. Okay, so why, if somebody wanted to know about the grandparents, because I said the parents are fine, but about the grandparents, why did you want to know about the grandparents? So this young boy with a swollen elbow, from where did he get that? We said that he's a hemophiliac. So who has the disease as well in his family? Okay, so which grandfather? Okay. Again, can you hear what I say about answering questions as well? You've got to answer in full sentences. Think of what you're saying. I know what you're implying. Well, you know what you're implying. But remember, the examiner doesn't know what you're implying. Okay, they don't make assumptions. Don't make the assumption that the examiner is going to make the assumption that you know that it is that one, because they can't do that. Okay, some will, but there is quite a lot that don't. Okay, so rather answer in full sentences. So the maternal grandfather. Okay, why? Because yes, we said it's an X-linked recessive disease as well. Okay, so medication, I already said. You guys did ask about aspirin, NSAIDs as well. We don't use aspirin in kids anymore, but remember the over-the-counter medication that can cause the platelet problems. Nobody wanted to know about any one of the patients' surgery history. Okay, so you can get a lot of information, but there's a lot of surgeries that is actually not so dependent on hemostasis, and then they can have a few problems, like circumcisions. Hemophiliacs doesn't have to have problems with that. They might, but they may not have problems with that as well. So just ask about that. Remember dental extractions. Okay, there you are quite dependent on hemostasis for bleeding. Okay, so before the multiple choice question era, there was lots of other either long essay questions, but the nice and easiest one to mark was tabulate for me the differences between a coagulation disorder or a platelet disorder. Okay, but it's also a nice way to study, to compare the two, to think of, to ask the questions. Petechiae, are you going to see it with a clotting factor disability? No, you're not. You're going to see it more with a platelet problem. Ecchymosis, okay? What's the difference between ecchymosis and purpura? Is there a difference? Okay. Exactly. Okay, you've got it right. Everybody uses the terminology purpura for smaller ecchymosis, okay? But purpura is actually just the collective name for the two together. Okay. So Dr. Kashalgan, he worked here before, he liked you to be precise as well, but remember the definitions of the two. Okay, so but we all think of ecchymosis of the big massive ones, but ecchymosis is just your bigger bruises, and then purpura is the collective name of the two. Okay, so you guys can go through this table. Okay, so joint hemorrhages, you've got family history of bleeding, sex of the patient as well, but in the end, an inherited problem from infancy is usually chronic or recurrent, and an acquired thing is an acute onset, can be any age, and there could be other symptoms as well. Physical examination, obviously you need to look at the patient and examine the skin thoroughly of the patient as well, just to think of it, and don't forget this little thing down here. Okay, so if you can't explain it, just remember that in the back of your mind. Don't make the assumptions. Quite a lot of my chronic ITP patients do look like children that has been abused, because there is bruises all over, but it is just, then again, they're very hyperactive kids that you see, because remember, the hemophiliacs and the chronic ITP children are the most busy children, okay, because they know that they can get away with murder, okay, because nobody can give them a hiding, okay, even though that is illegal to do that anymore, but they are very naughty as well, and they will be the instigators of fights and things as well. So that's why we will frequently see them. This table I've put in just so that you guys can see what the differences are. So coagulation defect has got a recurrent bleeding around friable clots, platelets, most commonly gum bleeding, intraoral petechiae, and hemophilia. It doesn't have to be a knee. We all know about the knee arthropathies, no, the hemarthrosis, so the hemophilic knees, but it can be anywhere. It can be an elbow, it can be any joint, it can be a hip joint as well, where these kids bleed. Okay, and then if you see symmetrical petechiae, just think of a condition called Henoch-Schönlein purpura. Okay, I've detailed for you a little bit, because everybody says if you're going to mention something, you need to at least know one or two sentences about the disease. So there is quite a few sentences for you guys about the disease. So the Henoch-Schönlein purpura as well. Broad scars, if you see that, think of factor 13 deficiency. And then if you find mushy skin, marked elasticity, confluent purpura on the shins, just think of Ehlers-Danlos as well. So I have given you a lot more detail there. Okay, so the gentleman next to the lady with the microphone at the back, what tests are you now going to do? So the patient presented with his epistaxis or with his joint bleed.
So you do a full blood count.
Okay, so you're going to do a full blood count. What are you going to look at on the full blood count?
You're going to look at all three, say, look at the patients.
Yes.
And also the anemia, the hemoglobin, see if there's a chronic thing. And your rise of lungs, you're thinking of a vacancy. And also smear.
Okay, obviously a smear as well. Okay. So, yes, that's correct. You need to go and look at that to see if that is normal. What do you do? You've got your answer on the board. And bleeding time. Okay. Can you see that I didn't mention INR here? Okay. When do we use INR? Warfarin monitoring. That's it. Okay. Prof. Kutsia will tell you that's what you use that for. Okay. So we don't use routinely INR in kids. Okay, unless they're on warfarin for some other reason, that they've had a clot or anything. Okay, so bleeding time. So if you've got a normal platelet count, patient is still bleeding, just think of, is it not, and your PT and PTT is normal, think of a platelet function disorder. Okay, so you need to go and look at your platelet function, and then we know about the PT and PTT, prothrombin and thromboplastin time. And you said we do a smear. Okay, so which one of these two full blood counts are normal? Left is normal. Your left, my left. If you said your left, it's fine. Yes, it's correct. Okay, your left is normal. So yes, there is. You can see the platelets. Those are the little purple dots in between, and you have to compare their size to the size of the red blood cells. Okay, so you can see they're quite small in comparison. On this one, there's just a neutrophil in the middle, but there is few, hardly any. So there is like one little platelet in between and a large one in here. Okay, so why is the platelet count low on the patient on your left? Platelet clumping. Okay, so if you've got a low platelet count, just check what the comments say, and you can see they are clumped. Okay, do you think these platelets are functioning normal? No, they're big. Can you compare them to the red blood cells? So they're almost half the size, and if you compare those little ones there, they are just a little dot or a speck, okay, in comparison with the two. So you need to look at the smears. Okay, I like visualizing and colors and things to remember stuff. Okay, so I'm just reiterating exactly what do you do. So you can see the intrinsic pathways in the red, extrinsic pathway is in purple. Okay, so PT, extrinsic pathway, purple. Okay, so APTT, intrinsic pathway, but both also looks at the common pathway as well. Okay, so this is just to remember it again. Okay, so that's why I've put that slide in. There's just a little bit more information. Why do you do the PT? It measures the extrinsic pathway. So if we've got a rare inherited disorder with factor 7 deficiency, that's going to cause a prolonged PT. Okay, exactly, that's what we talk about. Okay, and remember factor 7 is a vitamin K dependent. Okay, so vitamin K dependent, liver failure patients, isn't it? Hey? Okay, so it all comes back. Okay, you were not incorrect, but it won't be the first thing that you need to think of. Okay, so PTT, we said it's which pathway? Intrinsic pathway. Okay, so that would be the one that is prolonged if you suspect a patient with hemophilia. Okay, so factor 8 and 9 deficiency. Okay, and then there's all sorts of other tests that you can do, and once you've got a prolongation of one of them, you can ask them to test the specific factor levels for you. Okay, and then there's just a few more tests that you can do for bleeding time, the platelet function, to look at all of that as well. And as I said, tables are nicely to remember things. Okay, and to use these tests in the multiple choice questions is also, if you get a result where the patient is bleeding, but he's got a perfectly normal of everything, you need to think of a vascular disorder. Okay, so the PC stands for platelet count, the bleeding time is the BT, and then obviously your PT and PTT. And if you come down here, you can see your classic hemophilia has got a prolonged PTT, and Christmas disease. What factor deficiency is that? 9. Okay, I told you, that's why that other table is in there. Okay, factor 7 deficiency has got a prolonged PT. Okay, so factor 10 deficiency, common pathway. Okay, so both are going to be prolonged. Okay, vitamin K deficiency. Which factors are vitamin K dependent? 2, 7, 9 and 10. Okay, so you can see 7 extrinsic, 2 common, 9 intrinsic. Okay, so that's why both is going to be prolonged. You can work this out. It's just nice to see them, okay, in a table form together. Okay, so, and this is just another summary of which ones will cause a prolonged PTT, and that one must just remember that lupus anticoagulants can also cause an increased PTT. Okay, this is just transient after viral infections. And then if you've got prolonged PT but a normal PTT, think of factor 7 deficiency. And if both is prolonged, think of it, is it a sick child or a well child? And there's different causes for both of them as well. Okay, and this is also a nice way to think of it. If you've done it, if your PT and PTT is abnormal, which one is abnormal? PT prolonged, factor 7. PTT, it is now which pathway? Intrinsic pathway. Okay, so that's where your heparin and your hemophiliacs comes in. And then if both is prolonged, does the patient have liver disease or DIC or any other problems there as well? Okay, normal platelet count, think of, we said von Willebrand's. Why? Because it causes problems with platelet adhesion. Okay, so factor 13 deficiency, one must remember as well, platelet function disorders, low platelets, and this is nice picture of bone marrow that gets done in pediatrics. And I know that in adults now I teach my registrars, because your ileum is a nice big bone, okay, so you won't slip from there. And as you can see, you just need to get through the skin, through the outside thick layer into the bony trabeculae, okay, to do bone marrow aspirate. Okay, so you just need to be careful when you do these tests as well. Von Willebrand's is actually the most common inherited disorder, but we never teach you about this. I'm giving you just a few more information. There's lots of nice reading material, I think, in your files about that. What's the role of it? It stabilizes factor 8, and we said it has to do with platelet adherence. There's 3 types of von Willebrand's disease that you can get, so deficiency, or it can be dysfunctional, or it can be completely absent. What do you need to do? Do a factor 8 assay. Does it work or not? And then you can test your von Willebrand activity, and it manifests with bleeding, and this is what you do for all of them. Okay, so you guys can just read through that. Factor 13 deficiency, very uncommon as well. What did I say? What does it cause? What can you see on physical examination? Broad scars, okay, and it's usually the young babies that bleeds from the umbilical stump or intracranial without any other causes that one need to. Then one need to remember inherited platelet disorders, again, far more uncommon than the acquired platelet disorders. Okay, so these are the lovely names that you can throw around, okay, like Bernard-Souliers, Lanzmann's, Wiskott-Aldrich, and TAR syndrome. So who can tell me what the hell is TAR syndrome? We're talking about platelets. So what does the T stand for? Thrombocytopenia. So this patient has got low platelets. And the A actually stands for something that is missing, absent. Okay, so, and it must be something that is anatomically missing, that starts with an R, and you can see it from the outside. So what starts with an R? Anatomically. You will not, say again, I've heard it somewhere. Absent? Please tell us, what did you say? You can't see that if somebody doesn't have a rectum. They will look like this. Yeah, what is that? Radius. Okay. So TAR syndrome, I have had the privilege of seeing one patient in my life before, but you won't miss them because they need to, for your arm to work properly, you need a radius. Okay, so if you don't have it, your arm is basically going to be in this position. Okay, so the young lady that I saw with that. Again, like I said, I like colors. So the platelet problems can either be adhesion problems, aggregation problems. Okay, so problems with aggregation is your Glanzmann's, and problems with adhesion is your von Willebrands or your Bernard-Souliers that you've got. There's a summary of Bernard-Souliers as well. So the platelet function disorders, there's a summary of Glanzmann's thrombocytopenia as well. And then they are just them again, exactly where they work, what do they do as well, all three of them. But what I said in the beginning, one must remember that acquired platelet problems are far more important. Okay, so we know about the NSAIDs and the aspirins. Okay, but what must never forget, your renal failure patients that's in renal failure with the high ureas. Okay, platelets doesn't work. Okay, we've had a patient that was in tumor lysis syndrome, renal failure, urea 50 plus, and she was bleeding intracranially. We gave platelets for what it's worth, but eventually she died of a bleed. Okay, so these things, you must never forget these things, that if these patients is bleeding as well. So, and we've talked about the vascular purpura, so there could be structural abnormalities, connective tissue disorders that you need to go and look at as well. And then if you don't find a cause, that physical abuse should be considered as well. Or there could be one of these rare inherited disorders. So this is just a summary of what you need to do. So in the beginning, I asked you a lot of questions. The questions means that you need to take a history. Okay, so history taking is you need to talk to your patient, ask them questions as well. Okay, I didn't tell you what my patient looked like, but obviously when the patient walks into the room, you need to look at your patient for physical clues of why the patient will be bleeding. So you will examine your patient, but you will also look at inherited disorders. So there's dysmorphic signs, remember, just put them in there. Look at that, okay? Don't just go through the routine, think of it, okay? I want you to think, if a patient presents with a certain history, immediately you've got to have the causes at the back of your mind. Okay, so when I said the patient presented with the epistaxis, you need to think vascular, platelets, clotting factors, okay, coagulation issues. Okay, what questions do I need to ask for vascular? What do I need to ask for platelets? What do I need to ask for clotting disorders? Okay, if you get an answer, then you can move your questions into that direction. Okay, because the questions that I got was a little bit platelets, a little bit vascular, a little bit clotting, and then platelets, and then vascular, and then clotting, and it was everywhere, all over the shop. Okay, so then you're going to look like a poor little chameleon on a Smarty box. He's going to be in trouble. Okay, then you go for your specific screening investigations, and as the gentleman mentioned, you need to do the full blood count with a peripheral smear. Wait for the result from your hematologist, okay, and what they say about that, but then you will do your clotting studies as well, your PT, PTT, and then if you think of a platelet function disorder, do the bleeding time as well. Okay, and then think of everything, and if everything is normal, think of causes that won't, like von Willebrand's, platelet functions, like we said, and vascular abnormalities. Okay, so that's the first part of this lecture. What I want to get to, I've actually given you a nice handout about hemophilia. Okay, because we all know about hemophilia. That is not in your lectures, okay? So I've given you a lovely document about hemophilia. Okay, we know this is the most common inherited bleeding disorder that we all know about, except for von Willebrand's, okay? You know about the inheritance, and you need to be able to draw this. As we talked about the young man, his grandfather was affected, so his mother was a carrier, and that's why he got this, okay? But the next question would be, okay, and it's going to come up in the multiple choice questions, which we will answer at the end. If this mother comes to you now, she's got a hemophiliac boy, okay? So what is her chances with the next pregnancy, if it's a boy, for him to have hemophilia? 50%. Okay, remember that. And remember what I asked now. I said with the next pregnancy. Okay. Remember what people understand is, when people explain this to the mom, says, okay, if she's got 4 children, one of the boys will be affected, one of the boys will be normal, one of the girls will be a carrier, and one of the girls will be normal. That's what she's going to hear. It has the implication for each pregnancy. Okay, if you read your books as well, remember that's with each pregnancy, this is the chances. You've got a 1 in 4 chance, well, 50-50 if it's a boy or a girl. But then, these are 50% if it's a boy, 50% for the girl to be a carrier. Okay, remember that that's with each pregnancy. Okay, people do understand this correctly. My hometown where I grew up as well, 2 families where the first family, the girl was born with a cleft palate. Okay, so second pregnancy, it was a boy, perfectly healthy and normal. So she was pregnant with child number 3. There's another family, boy, cleft lip. Then her second child was born, again a boy, cleft lip. So this other lady hasn't had her 3rd child yet. She just prayed that it would be a boy, because in that family, the 2 boys is affected. And as it happened, she has a boy perfectly normal. The second family, 2 boys with the cleft lips. 3rd pregnancy, it's a girl, perfectly normal. So when the first lady fell pregnant again with child number 4, she again now hoped that it's going to be a boy, because that's how it works. The boys are perfectly normal. Okay, that's how people out there understand it. Okay, remember we all come from families as well, and one must explain these things properly. Okay, and once you've explained something to a family, ask them to repeat what you've said. Okay, sometimes they got the wrong end of the stick, or you gave them the wrong end of the stick. Okay, don't just accept that they do understand. Okay, we all throw in a lot of medical terms when we talk back to families. Okay, remember that you need to talk in a common language. If you don't speak their language, get an interpreter. Okay, somebody that can speak it appropriately. Okay, because it's really important that and especially with these inherited disorders, they need to know. Okay, and in the end, if some of these families actually know far more than you do about this disease. Okay, remember there's the lovely thing called Google. Okay, so they are going to Google. So they're going to consult Dr. Google and ask him lots of questions, and he's going to give them lots of answers, and they will want to know about them. So my answer to them is, bring me the information, show me the website, and I'll go through that with you, that I can interpret it for you correctly as well. So one must remember this. But again, back to hemophilia. We know that it is characterized by recurrent bleeding. Okay, can be due to trauma, but it actually doesn't have to be. Okay, we've said hemophilia A is what deficiency? 8. B? C? There is. Not 10. And that's the one that girls can get as well. 11. Okay. So don't forget. Go and read about hemophilia C. Okay, so this is the question. This is the, what do you call a genogram that I wanted to give you guys earlier. Okay. Remember the different scenarios. If the father is affected, all of his girls will be carriers. Is that correct? Yes. Okay. Because the only way that they can get B girl, they need both X, they need an X from him, and he's only got one, and that's the affected one. Okay. So, but if the mother is the carrier, if it's a boy, 50-50, girl 50-50. Okay. And hemophilia is also known as the, who's that? Queen Victoria. It's the royal disease. She was a carrier of factor 9. Okay. So apparently, and remember there was lots of marriage within all those families and things, and the Russians, the Tsars, were quite badly affected by hemophilia as well. So it is also known as the royal disease if you go through this. And we know why it is almost exclusively in males, but we've said in the unlucky circumstance where the dad is a hemophiliac, the mother is a carrier, that you can get a 50% chance if it's a girl that she will be affected. Okay. One must also remember, carriers of hemophilia doesn't have to have normal factor levels. Okay. So we have sisters, mothers of patients who's got factor 8 levels of 40%. Okay. So it will not make them bleed in everyday life, but surgery. Okay. One must remember that. So always test the carriers' levels as well. Okay. How do you diagnose it? I think we all know that they need to have a prolonged PTT, and the rest should be normal. And then you test for your specific factor as well. It can vary between severity as well, and as you can see here, unaffected people can have a factor level from above 50. Okay. A mild one is 6 and higher. Okay. Moderate 1 to 5, severe 1%. Okay. So your factor level can be quite low for you. 7 or 8, 9, 10%, you don't have to bleed on a regular basis as well. So it's got lifestyle implications for these patients. As you can see what the consequences are, the severe guys, they bleed on a very regular basis unless you give them prophylaxis, okay, so they can bleed spontaneously as well. Clinical signs, you must believe a patient that thinks it is bleeding. Okay. A hemophiliac that wakes up when the father phones me to say that, listen, little Wally is now, woke up this morning and he can't step on his foot. That's a bleed till proven otherwise. Okay. Doesn't matter if it was trauma, even if it was trauma, he will bleed in there. Okay, so one need to think of it. At birth, very uncommon, but we've had quite a few children and 1 or 2 that bled intracranially at birth. I've explained to you about this child from Anapu. Toddlers, they bleed frequently. Remember, they start walking and they fall over on stuff and things, so you need to make sure that they wear protective gear. Teenagers, again, they're very active. They want to join in. That is a picture of a Canadian hemophiliac that is actually doing cross-country running. So they can have normal lives, these guys. And this is a hemophiliac that climbed which mountain? Mount Everest. Okay. So you need to remember when and where is the most dangerous bleeds in these guys. So when would you suspect a hemophiliac to have an intracranial bleed? We know the consequences can cause brain damage and death.
The patient with hemophiliac bleeds or hematoma forms, and you said after...
Okay, so he's going to come and tell you, I've got a hematoma in my head. So what is he going to come and complain of?
Above his head.
Headache. Headache. Okay. Signs of raised intracranial pressure and headache is number one. A hemophiliac that complains of headache is bleeding into his head, in his brain, unless proven otherwise. So rather give him unnecessary factor. Okay. So he is bleeding. Okay. Remember, don't just ignore that's a small little bump in his throat. There's a lovely airway there that can be obstructed. Okay. And you need a lot of air to live as well. How much blood can you leave in your GIT? Loads. Masses. So you can bleed to death there. Obviously for men this is very important as well, but remember the eye bleeds, okay, treat them appropriately as well, these guys. Okay, so this bleeding has got lots of complications for these kids. As you can see with the joints, there is destruction of the joint with synovial proliferation. Remember, these recurrent bleeds, blood, there should not be blood within a joint space. Okay, so how did your body get rid of this blood that was in there? It sends inflammatory cells. So that's where you get the synovial hypertrophy. Remember, blood has got lots of what inside it? Red blood cells. Iron. That causes even more destruction inside those joints. Okay. And which toe are you going to hurt if the one toe is hurt? Hey? So you're going to bump that poor little big toe that is bigger than the other one. So that is why they develop a chronic bleed into one joint. So that's what they call the hemophilic joint. Okay, so they can develop. Remember, if they bleed into a muscle compartment, if that blood continues to accumulate into that muscle compartment, you can get lots of nerve damage, compartment syndrome as well, and then eventually they not going to use that muscle. So if I didn't treat that young man's bleed into his upper arm, he could have developed a contracture eventually. Okay, so you need to think of this. We said anemia, and remember, if they complain about hip pain and they're not walking because of hip joint, that they could have a vascular necrosis of the hip joint as well. That is very rare, but they can. Okay, so there I've summarized for you the symptoms of hemothrosis. Okay, so what will happen in the initial phase, secondary phase, and once the bleeding has stopped. But as you can see from this picture, the joint becomes destroyed in the end. Okay, so one need to think of them all of the time. So I've explained this. This is just a new term that it is called the target joint, that joint that is affected as well. Okay, and the target means that it is more susceptible to bleeding, and again, they can bleed anywhere. That we said, bleeding into the inflammation, I just like repetition. Okay, so read through these things. With a repeated bleed, the persistent inflammation, you get cartilage damage, destruction to the bones, and that's what they call hemophilic arthropathy. Okay, so the young man that I've explained to you, his grandfather actually needs joint replacements now because of the recurrent bleeding that he's had as when he was younger, and that is going to be a very easy thing to do. No, under the guidance of a hematologist. Okay, that it needs to. So basically, what is your treatment? You need to look at the lifestyle of the patient, and you need to give them factors. So you need to decide how frequently does this patient bleed. Can they get the factor just on demand, okay, so when they need it, or do you need to put them on a prophylactic regime, basically try and prevent it from happening again. Okay, so patients that bleed frequently, you obviously want to give them factor on a regular basis. Okay, so the way that we do it is we calculate, it's a lower dose than the treatment dose that you would give, okay, and you give it twice weekly. Okay, so unless the parents can give it, children has got lovely veins, so it's easy to drip them and no, it's not. It's very difficult. So we ask them to go to their local clinic or their local hospital to inject them twice weekly, unless my brother's had a roommate at school who was a hemophiliac, and when that guy woke up some mornings, he said, okay, no, my joints are stiff, and he actually injected himself. Okay, he was older, and that was high school, with big, nice, beautiful veins that he could give. So you can either give it at home, in hospital, and the prophylaxis can actually be constant, like we're doing with these kids, or I know one of the doctors who's married to a hemophiliac, and he loves playing polo. So during his polo contests, they give him on a regular basis factor, so intermittent, so high risk periods that you can give them factor. What factor do you give? Obviously the one that he needs. Okay. So fortunately nowadays they make recombinant factor, so that it is not made from humans as well, because what risks did they have, and what disease did hemophiliacs develop in the 80s quite often? HIV, okay. So because it was formed from other people, so now they make it for recombinant, so that you basically don't put them at risk for that as well, but you don't get away with the risks of inhibitors that they can develop as well. One must remember lifestyle, okay. So and we love to feed the little babies in these little high chairs, okay. Where's the baby's most weight? In his head. Oops. Okay, safety belts that they need to wear. Okay, so one needs to tell the parents about these little practical things as well. Okay, so think of them and what to do, and then we all know what to do when we've got an injured joint. You need to apply the little acronym called RICE. You need to rest the affected joint, so that's what they need to do. Rest it, you give an ice pack, you immobilize it, you compress it. In hemophiliacs, the C also stands for give concentrate, whatever concentrate they need. Okay, and elevate the joint, and remember, treat their pain. Okay, so for the hemophiliac I can give ibuprofen. What am I going to give? Paracetamol. That's what we've got, okay, or something stronger if you need to, okay, depends on. But if you work in the state sector and even in the private sector, you will realize that the other issues is that you are not alone as the doctor treating this patient. There's a nurse, there is a pharmacologist that has to get, or and a pharmacist that has to get the factor to the patient. There's a dentist that needs to look after these kids' dental health, okay, because you don't want them to extract their teeth on a regular basis as well. Then the orthopod that needs to help you with an orthopedist basically. And remember, these are boys that want to join in with sports and that they can't, so you might need psychologists for these patients. They can have severe pain, so if you're lucky to have a pain specialist that can help your patient as well. So this has got lifestyle implications of the patients. When do you start treating a patient? As soon as possible. Okay, so as soon as you can get the patient. The problem with this young man that I've explained to you with his hemophrosis is that he's got inhibitors, so we need factor 7 or fiber to give, but he doesn't have veins, not very good ones anyways, and he's a little bit overweight as well. Okay, so every single time that he comes, he needs to come to the hospital. So, and we need to give him a hemostatic dose as well. What do you think? Why does the parents only realize the next morning that he's bleeding? Do you think he will tell them? No. Remember, children hate needles in hospitals as well, so they will try and avoid, and obviously the parents will also sometimes think that, oh, maybe this is not a bleed. Okay, so you need to educate them what to do as well, and that you might need follow-up infusions. Okay, factor 8. Okay, how I remember this, factor 8, if you give 1 unit per kilogram, it increases the plasma activity by 2%. Okay, the half-life is short, so the 1 to 2, you need to give it twice a day. Okay, if you look at the half-life, 11 to 16 hours, so yes, that makes sense. Give it twice a day. But the 1 increases it by 2%. Okay, so if you know this is a severe hemophiliac and you're worried about an intracranial bleed, okay, so if he's severe, what is his factor level? Less than 1. So how much factor per kilo do I need to give him to get his factor to an appropriate level if he's bleeding into his head? How much do you want your factor level if he's got an intracranial bleed? 100%, hey? Okay, so how much do I need to give? 50 per kilo. Okay, so that's the easy way. For joint bleeds, half of that, 50% will be enough. Okay, so then you go 25 per kilo. Okay, factor 9 on the other hand, if you look at that, it's 1 to 1. I only give it once a day. Half-life, longer. Okay, but it's a 1 to 1. So, and the same principle, you think of, is it a minor bleed, is a major bleed? Okay, so I used the 100% and the 50% just more or less. As you can see, it falls into the appropriate ranges where you want the factor level, okay, to be. So that's the easy way if you don't remember and if you don't have your little booklet available. So factor 9, how many times a day do we give it? Once a day. By how much does it raise your factor level? 1%. So 1 unit per kilo, 1%. Factor 8? So 1 to 2. How many times a day do we give it? Twice a day. Okay. So one has to make life easy for yourself as well. I told you before, believe the patient who think he's bleeding, because any somatic complaint could be a bleed. Okay. So anything. So rather give them factor. If a hemophiliac comes and thinks he is bled, rather give him the factor and then try to prove or disprove it or whatever, okay? But don't wait and tell him that, no, I'm the doctor, I know better than you. Remember, they know their disease better than you do, okay, in the end, because that's all they have to go and read up about. You've got to read up about everything, okay? So, and we said if there's poor recovery or poor clinical response, test for inhibitors. But one must also remember, we've had a patient where they gave factor 8 to and said it doesn't work. He came from Kroonstad. And when we tested, he was actually a factor 9 deficiency and not an 8 deficiency. So, do you have the correct factor? Is it the correct patient? Okay, because there's many patients. You can't always remember them as well. Did you give the correct dose? Fortunately, we don't have to store these things in the cold anymore. Okay, the recombinant factors can be stored at room temperature as well. And do they have inhibitors or not? Okay. Criteria for admission, I think that's obvious for dangerous bleeds, trauma, surgery. We talked about the immunological issues. They can have allergic reactions, and then about the bloodborne pathogens that they can get as well. So, and then complications, as we said, the inhibitors as well. Again, that is basically a response to a foreign protein that you give to the patient. Far more common with hemophilia A. Why? Because you get far more commonly severe hemophiliacs, okay, with less, so they bleed far more often as well. And it again, one needs to ask for it specifically, and I have this issue with AMPATH. When I ask for the factor 8 inhibitor level, they always just tell me it's positive. It's like, wonderful, I know it's positive, I just want to know how much is it, okay, because as you can see, it is quite severe. If it is more than 5, it is severe. So this young boy, I started with more than 20, and the implications has that you can start with your immune tolerance against this if the inhibitor level is less than 5, okay, because the theory behind immune tolerating them is that you want to use up the antibodies, okay, so you keep on giving them factor 8 if he's a factor 8 with inhibitors to use up that and try to, so that they can use that again in later in life. So, because that's got lots of pharmacoeconomic implications as well for these patients. Okay, so your risk factors, obviously we said your severe patients, and obviously if there was an inheritance thereof, and we see it far more in the black patients that can get inhibitors, but we've got I'm treating 4 or 5, 2 of them is white boy patients and 3 is black patients, so it doesn't really matter which one has got it, one has got to look at that, but the consequences thereof, these kids can bleed, have life-threatening bleeds, it's got lots of morbidity, and again factor 7, and these things are only available at a hemophilia center. So our poor patients from Bethlehem and Ventersburg has to come here to be treated with a factor, whereas the others with the inhibitors and the others that is normal hemophiliacs can be treated anywhere else, okay, at their places. So it's got lots of implications. So you don't want to drive always when you are bleeding. So it depends on where the parents can work as well. And again, to use factor before surgical procedures, again, it got lots of risk. And as you could have calculated from before, factor 7 costs a lot of money, and even the other factor costs a lot of money, fiber. So that has got lots of implications on these patients, so, and the medical aids, and so you can read what you have to do with these factors. We talked about factor 7 that we're going to use, and as you can see, there is the activated prothrombin complex concentrate factor 8 inhibitor bypassing activity. Okay, they've done a study to see which one will people use more, and it depends on what time of day. They said because this one you can give 12 hourly, and this one has a short half-life, so it's every 3 hours, 3 to 4 hours that you have to give it. So it depends on, if you come after hours you'll get fiber, and during daytime hours when there's lots of people you get factor 7. This one has got a risk of that there is actually a little bit of factor within it. Okay, I've treated my one patient with a medical aid on factor 7, then the medical aid complained about the amount of money, so we used that one, but his inhibitor level was more than 20 when I started. It dropped down to 5, and when I used this one it shot back up to 18. So in that poor patient, it will be the unlucky one where it showed that he actually had that as well. So what do you do with them? You immune tolerate them, but it is not always successful, okay? And if it was successful, then you can use the concentrates for up to a year or longer. But as you can see, it's got cost implications. My issue with my patient at the moment is that he doesn't have very good venous access. Okay, so now I have to find a surgeon that will help me to do an AV fistula on him, so to improve his venous access, that we can give him factor twice weekly. And I don't know if I've got somebody that can do that, and then it is obviously lots of time and labor intensive as well for these patients. Okay, so that is it. Thank you very much, ladies and gentlemen, for a very long afternoon.